There's a lot of sub-Is in the ER right now, and I feel like oftentimes in medical training, people try to say the right thing. So here are a couple things that are never going to be the wrong thing to say. Number one, did we get a finger stick? Never going to be a wrong thing. If it's code stroke, if it's an altered MEMA, if it's someone whose eye is a little down and out, they're having vision changes, whatever. Did we get a finger stick? Always the right thing. Two, hey, I put that patient on the monitor. Never the wrong thing. Even if they're not that sick, even if I don't think they needed tele, if you cared enough to put them on the monitor so I can see vitals when I walk into the room, super dope. Love that. Three, I know med students love their whole, I did McMurray's and an anterior drawer, not that sensitive. If you expose a limb that hurts, like say someone comes in with leg pain, and you're like, hey, they're in a gown, you can see their leg, and if you say 2+ pulses, compartments are soft, immediately not the dumbest thing I've ever heard. Number, whatever I'm on. If I show you an EKG and you have no idea what it is, but you say, hey, what's their potassium? Fantastic. Never going to be the worst thing I've ever heard. Because if I'm like, hey, good point, it's a little high, what do you want to do about that? Good discussion. Or if I'm like, oh, completely normal, but a good question. Still always fair. And it buys yourself time to look at the EKG you don't know anything about. Number 5, I think. Hey, I put the ultrasound in the room. Easy way to my heart. And a lot of our hearts. Even if it's, oh, they're here with chest pain and shortness of breath, I put their ultrasound in the room, right? You can talk about PE. You can talk about effusions. You can talk about the 5 E's of cardiac ultrasound, which is usually a topic that's favorite of ours. That's entry, exit, ejection, effusion, and equality, right? Even if it's like a musculoskeletal thing and be like, hey, their knee's blown up. I don't know. Let's put a probe on it. Love it. Never going to be the dumbest thing I've ever heard. Number 6, already having something in a differential is usually not that hard, especially for sub-Is. But having a couple weird things in the differential is usually a crowd favorite of mine. Because if someone comes in with abnormal LFTs and maybe they have hepatomegaly, if you believe strongly enough that you can feel that, and you bring up some lysosomal storage disease that I haven't thought about in 6 years, I love that. It forces me to learn. And maybe you can teach me something, and that kind of relationship usually lends well to a sub-I and getting good evals.